deliberate on issues that concerns our Jamaica land with love. And as we meet today on this COVID issue, we hope that all information, all suggestions, all advice is taken into consideration in the interest of our people, Jamaicans. This in these words, we thank you in Jesus' name, amen.
Thank you very much, Member Don. All right, are there any apologies for absence, please? Any apologies? No? All right.
Chairman.
Yes.
Well, I'm sorry, let me not preempt you. Let me see what's the first item and then I'll come after that. I'm sorry.
Okay. All right, no apologies for absence. I'm going to ask now that first of all, let me apologize for the late start. I know it's not an excuse, but today is International Nurses Day, and I had a Zoom meeting with the nurses, their association and leadership across the country, and it went over beyond the time we had planned. All right, so can we move into the minutes then, and then so as the process, the
Chairman.
Yes.
Just a word. I'm pleased to have your apology, and I believe that it is in fact was for a worthy cause. But I want to suggest that when we have these meetings, because sometimes there are some other activities in which you're involved, and it means that we end up waiting for a while. While I can appreciate, especially this time, how busy you are and how your presence is demanded, I believe that we need to do a little bit more careful management so we don't have individuals waiting a half an hour or so on the meeting to start. I just wanted to make that suggestion.
Point taken. I know it's an unusual occurrence, but nevertheless, I fully appreciate the point. All right, can we go into the minutes, please? Pages 1.
Unusual occurrence.
I don't know if it's page 1.
Standard procedure, I think is what you meant to say.
Pages 2.
No, I don't know if it's page 1 or page 2, Chairman. It is a correction that I had actually made at the last meeting around the word underline. That was changed to underline. The point I made then is that we speak of underlying medical conditions or underlying conditions. And I'd just like us to keep that spelling consistent. It's neither underline nor underlined. It's underlying.
And it's not really spelling, it's a different word altogether.
Yeah, that's what I'm saying too. Yeah, no point taken, Mother.
Thank you.
All right, so that was page 2. Okay, page 3.
Chairman?
Yes.
On page 3 in the second paragraph, line 4,
right.
The word asked should be ask.
Line 4, okay, fair enough. All right, noted. Anything else on page 3? Page 4.
Chairman. First line. Universal supposed to be transport media instead of test machines.
Universal test machines, right?
No,
right.
But it's supposed to be transport media.
Yes, okay. All right.
And if I may, the second to last line in that paragraph, it starts off, well, the third line. Member Golin asked what was the use to the UTMs. It's supposed to be of.
Okay. That is where again, remind me?
It starts at the third line in the first paragraph. Sorry, the third to last line in the same first paragraph on page 4. Member Golin, that's where it starts.
Right.
Asked what was the use to the UTM.
Okay.
It's supposed to be of.
Right. Page 5.
Chairman.
Yes.
Page 5, the end of the first paragraph. How many Cobus machines we have? Is it one?
Yes, the one at the National Public Health Lab.
Right. Of which 1,000 was for the Cobus machines. There's a S there. Can we have that S removed?
Noted.
And put the word the for the Cobus machine.
Right.
Okay. Page 6.
Chairman, I would rather at the end of the paragraph, the chairman noted the suggestion instead of the concern, because it wasn't really a concern I had up here. It was a suggestion I'd made.
That's weird on the member.
End of the paragraph, first paragraph.
Right. Okay. Page 7.
At the bottom of page 7, Chair, penultimate line of the page, it should not be infectors, it should be vectors.
Vectors, yeah. Okay. Page 8. Page 9. Ten. 11. 12. 13. 14. And of course, a few lines on page 15. Okay.
Chairman?
Yes, member.
The clerk pointed out that we ought to ratify the section of the meeting that continued after we lost our quorum. I'm not sure from the minutes when exactly that was, but I did note towards the end of the meeting that we no longer had 4 persons present, 4 having been told that 4 was a quorum at some point. I think last, yeah. So
That's probably literally the last page.
Any other business?
Anybody can help us with that?
Yes, right before any other business.
Right before any other business. Okay.
Right.
okay, thank you.
That was when you left, Angie.
Yes, I'd forgotten that I was part of the quorum. My apologies for that, by the way.
Okay, right. So can we move that the ratification takes place?
Aye.
So moved. Seconded.
Okay, thank you. All right, so can we ask for the minutes to be adopted?
So moved.
Thank you, Member Golden, seconded by Member Guy. Thank you. And then matters arising. Just to say, members, that the Chief Medical Officer who is in the room will make a overview presentation of the state of COVID as we normally do. And then from there, we can flow into a conversation or discussion. So if you have a matter that you think would be taken up in that and you want to wait, otherwise we can raise any matter now from the minutes.
Page 2, Chairman.
Yes.
The matter of the infirmaries and we indicated at the last meeting that there'd be mobile units to test for the caregivers there. What is the status on that?
Right. So that process has started. Well, the communication between the parishes and the ministry. I know in the case of St. Catherine, a discussion was had yesterday with the Minister Mackenzie, where both the caregivers or the management of the infirmary has been in touch with us, and they are to provide us with the dates for the mobile unit to present to the location for testing to be done. We're actually waiting on them. I had a discussion with Minister Mackenzie yesterday as it relates to that. They have provided us with the names of the persons, We are now awaiting their request for alerting those persons and finalizing a date, but it is in train. I expect that by next meeting, we would have commenced that process. Any other matter?
Chairman, on that matter, I mean,
Go
what's
ahead.
on that matter? Thanks, Mark. Chairman, you indicated that starting the week of May the 11th, the app would be able to deal with persons who want to apply to be tested. Can you give an update on that? Because up to this morning, I checked it hadn't been there yet.
Right. So we still have the rest of the week to go. Today is Tuesday. This is
No,
the,
Chairman said
is
the
no, I'm coming.
you know.
We're gonna respond. I'm gonna ask the CMO to respond. That's the app, that the Jam COVID app that allows you to apply for testing or express an interest in being tested via the app. We had said that we would activate that during the course of this week.
Right, so before coming into this meeting, I just double checked with all the regions to see if they were actually, if their sites were up and ready. So we know that the sites have been selected and they're on the website. What do you mean by it was not up?
The last meeting we had, CMO, the minister indicated that individuals would like to get tested, that they could do the application through the app. I indicated that the app does not have that feature. We were advised that by the week of the 11th, the app would be up to have that particular feature. It is still not there. And that hence the question.
Which app are you using, Dr. Guy?
Jam COVID app.
We checked it last week and it was up.
No.
Dr. Guy, I don't want to give you the wrong answer. I'm going to wait until the PS comes because we had checked last week to see if the app was up, and we did try it to see if it was working. So I'm a little bit surprised to hear that it is not up now. So can I just wait until the PS comes in to give an update on that?
Okay.
All right, any other matter?
Yes, Chair.
Yes.
It's minuted that I had asked what was the total complement of the various categories of public health workers who can be deployed in the field to do track and tracing type work.
Right.
And I wasn't able to get a response last meeting on that.
Let me add some checks on that. Let me just indicate that the contact tracers are persons who are originally assigned based on their specialty somewhere in the public health infrastructure. So they are primarily public health nurses, public health inspectors, community health aides. I mean, we even use dental.
Well, we would have recruited additional persons.
I know, but what I'm saying is that so the numbers vary. Saturday I was in Anota Bay, for example, or Dover and Anota Bay. We had 70 persons there, and they were titled among that group. We have had 250 or so in St. Catherine, some pulled from St. Anne. So, in other words, sorry, from St. Thomas. In other words, the numbers will vary depending on the need, but they are pulled primarily from the existing work at the primary healthcare level, and some additions. Maybe the CMO wants to comment.
Yes, I just want to say the categories of workers that are normally assigned that duty across the island: the public health nurses, the public health inspectors, and the contact investigators. Those number about 684 across the island. However, in dealing with an outbreak, what we do is we recruit from all the other disciplines within the primary healthcare system to provide additional persons for that. So, for example, we use the dental health aides, we use the the mental health aides, we use the community health aides, we use vector control workers, we use, especially when you have a targeted intervention and you want to have 200, 300 people on the ground at one time, you're going to be pulling from all of those cadre of persons to have that kind of targeted intervention. But the actual persons that are actually in the system designated for that purpose are actually about 684. But all the time, in response to every outbreak, it is a recruitment from other areas to assist.
Which is why I would want to give a specific number.
So with the recruitment, what is the sort of total potential cadre that we would have if we were to recruit all those other categories that can be made available if an epidemic like this occurs? How many additional persons are available, theoretically?
Well, you've been talking about the primary health care workforce. I can't give you that number, but pretty much what you'll be doing is recruiting the primary healthcare workforce that is there. And even in response to what is happening in one parish, you would recruit from other parishes to help. In terms of the community health aid program that we are expanding, our required ratio is 1 to 1,000 population, which would give us about 2,800 persons across the island that are community health aides. So in preparation going forward, we have gotten additional posts that have been approved by the Ministry of Finance, and we are now recruiting those additional persons. We already have about 1,000 persons in those positions who would be added to that 684, because we would not have placed them in that category of persons for contact investigation, but we utilize them. So we would now be recruiting another over 1,000 persons to assist in this area. In addition, we have not actually put the numbers on the additional public health inspectors. And we recognize that the public health inspectors is a fixed training, it's a fixed qualification that you need to have. But there is a group of persons that are like auxiliaries to the public health inspectors that we are now working with the public health, that team of persons, to identify what is the gap, how many persons that we would want to have these persons recruited now to be utilized in that area as well.
What is the qualification to become a community health aide?
You have 2 levels of qualifications. So right now, what we have in the system is one level of community health aid. And that actually is an on-the-job training. And I can't remember offhand. If you wish, I can pull it up to find out, because I have it somewhere here, the qualification. But it pretty much is persons from the communities that were recruited and they had on-the-job training. I'm not sure if we had at that time when we started this program, if there was any requirement for any subjects or anything. It was mostly.
No, but the Heart Trust NTA does training, a 7-month training program for, among other things, community health aides. I've had a program like that in my constituency, and they normally recruit persons with a few subjects as a minimum requirement, 3-4 subjects from high school, and then they train them in all the basics of basic healthcare, public healthcare at the community level. So I know that there is a specific training program for them, and I know that Heart offers that program. But the answer to your question, member, is clearly it has to, the extent of the numbers required would be dependent on the assessment of the risk and the emergency on hand. In the case of our COVID response, the numbers that we have requested and gotten approval for is somewhere in the region of 1,000 to 1,200 additional staff over the next 12 months to manage the community or to support the existing fleet on the ground to manage the potential risk of COVID at the community level. And the idea is for them to become significant public educators around COVID in the communities, to promote some of the best practices, to identify the risks, whether the risk from particular circumstances, but also individuals. And of course, in the unfortunate event that there is a COVID outbreak in a particular community, then they become this sort of chief coordinator working with the rest of the community infrastructure to deal with that scenario. So that's the idea. There is a modeling that we're developing for the next 12 months. And I am going to ask the epidemiologists in another few meetings to make a presentation as to what the expectations are and how we intend to deal with that in terms of some of the things that have to be adjusted, which includes capacity, human capacity.
Yeah.
Chairman.
Thank you. One sec, Dr. Just to make the point, the reason why I have asked what the cadre is, or the cadre is, and you gave the 670 or thereabouts plus an additional 1,000, and you're trying to recruit another 1,200 or thereabouts, is because, I mean, we've been fortunate really that our clusters have kind of come sequentially. But if we were to have multiple outbreaks or multiple clusters in different parts of the island, we would be, obviously, the question of our human capacity and other resources to deal with that is a live issue. So I wanted to get a feel for what we currently have available to us. So thank you for that information.
Okay. I see Member Brown has a hand up.
Yes, I do. I wanted to go back to the question asked by Member Guy around the infirmaries and the nursing home. I got the impression when you answered the question that you were speaking specifically of the infirmaries. And you know that we have been asking the questions about both the infirmaries and the nursing home, although I have noted what you have said about the nursing homes and those that are not registered. Minister, so I want to ask, specifically for nursing homes, is it the same case for them as it relates to the testing of caregivers and what is happening there? So that's one. Secondly, we spoke last time also around some of the protocols that were to be established and were to be sent to these nursing homes and infirmaries. And I just wanted to ask that the protocol be just widely shared again as we're talking about it with the public, because I believe that the public has a role in helping us to make sure that these standards are maintained and the protocol is being observed.
Right. So the Standards and Regulations Division of the Ministry has been instructed to not only provide a specific COVID standard for nursing homes, but also to visit with these homes. And I've asked them not to discriminate in terms of registered versus unregistered, because we are concerned about the possibility of outbreak in any of these facilities and the likely impact based on the clientele. And up to last week, I spoke to them, and I know that that is happening. It's a number of them, and we don't have unlimited staff. I think the last count I saw was what, 200 and just over 200 or 100 high. So it is happening. It's a work in progress, and I'd be happy to share what has been prepared. Make a note of that and share that. But yes, I've been in touch with them because I do see nursing homes. We see nursing homes and infirmaries as a vulnerable.
So this is the third week I'm asking, Chairman. I believe that we need regular updates, and although it's a work in progress, I believe it's going to be important for you to share as you go through,
what I'm going to do,
calling the names, what is happening and what is the state of.
What I'm going to do, member, and I'll make a note of it, I'm going to invite the head of standards and regulations to the next meeting so that she can give an account of what is happening, if that's fine with you. because I think it would be good to get her perspective on what she's.
Absolutely, that's kind of what I've been asking for. I think we need to just shine some light on it so people are very clear on what's happening there.
You were not,
And
you
that
were not
you're on top of it, we are concerned, and we are making progress. I think it's important.
All right, so we'll make a note of that, and I'll follow through on that.
Chairman,
Any other matter? Yes, member guy.
I had asked a question. Well, I had my hand up. Dr. Bisesa, you said there are about 1,000 community health aides currently on your staff, but wouldn't it be fair to say the vast majority of this 1,000 that is there is are basically confined to the hospitals and health centers, and very few are in the field?
They would all be attached to the health centers and the health departments or the hospitals.
No,
So
but providing other services at the hospital, if I may.
Right, so it's a minimum actually of CHAs that we have in the hospitals. The CHAs in the hospitals you're going to find mainly are going to have to deal with, maybe you may find one or two in the emergency departments that help with oral rehydration. But mostly in the hospitals, we have the PCAs. That are another category that provide the same kind of service, but it's a different category of staff. So the community health aides are the ones that wear the blue. Those are mostly in the health centers and the health departments. And so within both areas, they have a job description that includes their community work.
Member, let me expand on that, if I may, member. There is no doubt, and it would be foolhardy for any of us to think that the stresses that existed prior to COVID are not doubled with COVID now on hand. And as it relates to all the work that our practitioners have to do, including the public health ones mentioned, that they have to now juggle between both. We have been able, I think, to direct and redirect and to pull on resources as required, depending on where COVID touches down and where the risk is assessed to be greatest. So we have pulled persons from a parish and assigned them to another parish, for example. It has resulted, no doubt, in the less than optimal performance of our other functions because of the reassignments that have had to take place. I think the government is very seized of that. We certainly in public health are, not to mention the fact that we are bordering on burnout in some instances because persons have to work long hours. Hence the approval of the government for the additional staff, recognizing that this journey is not short-term, and we're now actively recruiting so we can complement or support those who are currently in the field, so that the other work can go on while we do what we have to do. So you're recognizing a problem that exists. I think you should also recognize the efforts at solving the problem.
I think you missed the point I'm making, Minister.
Yeah, but
no, I just want
you're missing the point I'm making, with due respect. I'm only saying that the 1,000 that the CMO mentioned, the vast majority of them are doing work in the hospital and in the community health centers. And therefore, if you remove them from the hospital to do other work as you're suggesting now, then it would impact on the services offered at the hospital. Therefore, even if you include the 1,200 that you're proposing to recruit over the next 12 months, the reality is that you may not have as much as you were hoping for to add to that 1,000 that is out there already. That's the point I'm making.
No, but hold on, member, hold on a second. But we're not saying with due respect, and I know we're all trying to achieve the same objective. So please accept my comments in the spirit for which it is given. You and I are not saying anything different. Of course, it's going to affect the numbers. Which is why we're getting the additional 1,200. It will, which is why we have to beef up and get the additional numbers. But should the need arise, we have to deploy and redeploy, and that's the point. That's the point I think we're making. But your point is taken. Your point is taken. Can we move on, please? Can we move on?
Yes, Chairman. On another matter, CMO, can you say if you got those 5,000 transport media kits that were supposed to have arrived during the week of the meeting of last week?
from IAEA?
Let me just check on that, Dr. Guy.
He's checking on it, member. Can you have another point on the matters arising?
Yes, Master. You were supposed to have asked the permanent secretary minister last week to report on the number of private general practitioners who had accepted the arrangement with the Ministry of Health to allow 75,000 patients within the sector to be divested.
I wanted to just comment also on the Jam COVID website, which was asked when he was out of the room. Yes, comment on those.
All right, good morning. Good morning, all. I'm Chairman. The Jam COVID website can take appointment, but the work, and is taking appointments, but the work, the process flow in the app is that you first have to report yourself. So you have to report yourself, and then once you report yourself, it asks you all of the relevant questions. And then based on the response to the questions, it kind of prioritizes you. Once you get a prioritization, you get a code, and then you have to go back to the appointment tab and then click on that tab, enter your code, and then you're able to make an appointment for the health centers that are within your parish, or the one that is closest to you. However, each health center has a set number of time slots and a set number of tests that can be done in a particular day. And right now, we are on in the testing of this side, we only booked time slots for a week in this first instance, just to make sure that the process works in the live environment.
So you're saying essentially, Pierce, that it is the same section of reporting yourself that you can book an appointment.
So no. So if you when you go on the app, you'll see report yourself, and then you'll see a button underneath it. And I think that is the confusion. I think it needs to be changed. You'll see a button that says make an appointment, and then you'll see another button that says report yourself. But in order to make the appointment, you first have to report yourself.
Well, that information, then that is what the public needs to know.
Yeah, I recognize that is a challenge, because I think people think that they can just go, because when you click on make an appointment, it asks you for the code, and you only can get the code when you report yourself and go through the the assessment process. And then the next thing
he says he has accepted. Let's move on. You have any other matter? Oh, the PPP. Sorry, he never addressed the PPP member. Sorry.
So what we found from the PPP, we got 58 applications out of the PPP process. The major challenge that most persons are having when we did a canvas as to why we got such a low response rate is the requirement for a TCC. And the local GPs are saying in order to get the TCC, they would have to do several. They'd have to engage with NHT and then engage with NIS and so forth and so on. And the time that's required to get that done was not sufficient for them to get the TCC in order to make the application timeline. So what we are going to do is that we are going to look again at the process, at the requirements, and then see if we can tweak it so that we can get more response. But we're going to proceed with the first 58 and begin to engage them in a framework agreement over the next 2 weeks.
So remember, 58 private practitioners have responded. We'll work on those while tweaking the requirements to get the full the geographic spread that is required to deal with the issue. So we'll proceed in a sort of phase 1 approach. Any other?
On that point, Dr. Guy, if I could just make a suggestion.
Sure.
In relation to services procured by the public sector, or banks for that matter, professional services, if the service provider doesn't have a TCC, a withholding tax is applied, which the person can then claim as a credit when they file their tax return. And the rate of withholding, I think, is around 2 to 5%. I can't remember the exact
5%.
amount.
5%. Right.
It would enable you to build, to get the necessary quantity of private practitioners you need to divert cases away from the public health institutions, so you can focus on COVID without requiring persons to get a TCC, which is not a quick. It's not a quick fix.
Yeah,
it can take years to get a TCC, depending on the problem or whatever issue you may have with whichever statutory agency which needs to be resolved. So I suggest that you consider using that methodology to solve the problem.
Thank you, member. Point well taken. Member Guy, you had your final point, and then move on to.
Chairman, the final point was on any other business that you had committed, based on the minute, that you would have found out regarding the other occupants of your head office building, whether testing work was done on those persons.
Testing done on any of the non-Ministry of Health people in this building, the call centers.
The call center?
Yeah, I know we had communicated with them when we had the positives.
Right. No. No, we did not. We tested staff, and we tested persons who were aligned to the ministry in terms of service provision. Yes. So and based on the investigation, the security officers were tested, the cleaners were tested, and it wasn't deemed necessary to test based on the contact tracing and investigation to test for other persons within the building, the physical space.
Thank you very much. Can I ask the CMO now to just quickly give an overview of the current state of affairs as it relates to COVID?
You might need to share your.
You want to share the file, or you want to just? All right. You have it. Just begin, and then I'm going to ask her to begin, and then we'll try and bring it up at the same time.
Right. So up to yesterday, we had 502 confirmed cases. In addition to that figure from yesterday, we had 3 more that were confirmed. So that brings us to 505. And therefore, you would see that we have 38 imported cases. You know that we have been treading along 35 for a while. So now we are now up to 41. That's
41, yeah.
41 with the additional 3. So those six of those 6 imported cases would have come out of the re-entry program that we had, that we brought in 121 persons, and 6 of them from the TUI group, which is the group with the ship workers, are positive. So they have been placed in isolation, and we are monitoring them. And we have some, based on the contact, we would now start the contact investigation in terms of those persons who would have tested now, who they would have had close contact with within the same group, to identify retesting strategy for those persons. We have 24 persons now that we have classified as local transmission, not epidemiology linked. Of course, anything that happens here would be local transmission, but not epidemiology linked, meaning that they are not linked to an imported case. We have 190 contacts of confirmed cases. 25 are related to the imported cases. 60 are related to those cases of local transmission that there is no relation to an imported case. 95 cases to the Alarico workplace cluster, and we have 10 contacts of confirmed cases that are under investigation. We still classify 250 persons under investigation. 224 of those are within the workplace cluster, and 26 other cases. So in all, we have 319 persons in the Alarico cluster outside of that are in the 505 confirmed cases. So our new cases, therefore, would have been the 6 cases that we have identified for the the now imported cases. And over the last 72 hours, we would have had those 6 cases plus 2 cases from St. Catherine and 1 case from Kingston and St. Andrew. In terms of our parish.
Just a quick question on that. The workplace cluster, did that originate, do we know whether that originated from an imported case, or we don't really know how that workplace cluster originated?
There's still some investigation that is going on, because we have identified 1 or 2 individuals that traveled, that had a travel history. I discussed this just last week with the Epi team for them to look at those 2 individuals again, to look at the timeline of their travel and their interaction during the period that they just came back with the Alarica group, because I believe that these would have been probably external persons that may have been doing training at Alarica. So we are looking again at those 2 persons. Our initial information suggested that their timeline may not necessarily support that they would have been the persons that introduced it into the company. However, we've just asked them to look at that again, since these are the only 2 cases that we've seen where there is a history of travel.
All right, I'm going to begin to share the screen now so that the presentation can be seen.
Just go to the page that you're.
So in terms of the parish distribution of cases, again, the majority of our cases are in St. Catherine, which is 293 cases in St. Catherine. Next is Kingston and St. Andrew with 107 cases. Next is Clarendon with 35 cases, and now St. Mary with 18 cases. And then you will see the others there. Again, Hanover still remains a parish that we have not had any cases in. The next slide gives you a breakdown in terms of the case count by community. And you can see that St. Catherine has the communities that feature at the top of the table. Most of the St. Catherine communities are where we have the highest load of cases, but also in Kingston and St. Andrew, you will see Constant Spring and Delacree Pen, and Bull Bay, of course, that we had or other cases. And then you can see going down the number of cases by community. Our next slide shows the confirmed cases by community on a mapping of this. And you can see that the denser areas lie within the St. Catherine area, in Old Harbor, Linstead, Spanish Town proper itself, and in Portmore. And again, in terms of the confirmed cases by community for the workplace cluster, you will see that there is a significant similarity between the 2 in terms of having the bulk of our cases coming from the workplace cluster. The distribution in terms of density is similar to the overall map of the cases. In terms of the tests performed, and these were yesterday morning's numbers, with 7,101 total tests performed, 502 are COVID positive, 6,546 are COVID negative, 53 cases are pending, and 7.1% positivity rate. In terms of the clinical situation, we have 419 persons who are in isolation, and 49 of these are isolated in hospital. We have no critically ill persons at that time, and that still remained up to this morning, that we have nobody that is critically ill, and 3 moderately ill persons. 9 persons, as we know, have died, and all had one or more underlying conditions. In terms of the—
Sorry, CMO, in the previous slide, what the slice of the pie that said step down, just clarify that for me, please.
Okay. In terms of once we start having the discharge criteria is that you should be asymptomatic for 4 days. Once you are asymptomatic, we do the first discharge test. If you have 2 consecutive negative tests, then you would be discharged. So essentially what we were finding was that we had a lot of persons in hospital that were asymptomatic that were waiting on discharge testing. So once we've started the discharge testing, we move them to a step-down facility.
Like a convalescent home, halfway house, so they don't use up the hospital bed member.
Right,
So
understood.
okay.
Thank you.
The number of confirmed cases, we look at the line graph, and we see with the Alarica work cluster, which is in the solid line, and without the Alarica case cluster in the broken lines. So we can see that in terms of the Alarica numbers, we are leveling off now. We do continue to get new cases of contacts that we are still, so you will see that we will be getting some positives that are still being reported for contacts of Alarica, because we still continue to do the investigation of the contacts. And we are doing repeat cases of some cases that would have tested negative that may have been in a high risk group as well. The next slide, you will see in terms of the doubling, Jamaica initially, as you know, we had started off on the 8-day doubling line. With Alarica, we went up to the 5-day doubling line, and then since that, with as the epidemic has continued, we have now trickled back down. We are now below the 10-day doubling line, but we still continue to maintain a high level of alert and to continue to do our testing and to expand our testing protocols to try to reach as many persons as possible. We look, the next graph, the next bar chart looks at the number of cases by date of onset. You will see that in the green, you will see the symptomatic cases. And in the purple, you will see the asymptomatic cases. You will notice that at this period of time, most of our cases we are, as a matter of fact, from about the middle of April, most of our cases are going to be detected through contact tracing and other case investigations. And so you will notice that most of our cases now are going to be lying towards the asymptomatic cases rather than the symptomatic cases. So that's what is happening now. Our pickup is coming through our contact tracing.
What does unknown mean there?
What happened is that we would get, it's really how the reporting is done. The lab tests, the request for the laboratory test comes in and the test is done. But many times we don't get the notification forms, and we have to be doing the investigation after to say who are these cases, and therefore now to find out what were their symptoms and when was their date of onset for their symptoms. Many persons that we would have picked up through the contact investigation or the case investigations would have no symptoms, and so there would be no date of onset. And so we would have just notified, we would have put them down as when we detected them, not necessarily as their date of onset of symptoms.
The unknown relates to the fact that you don't know when the symptoms began. That's what the
the unknown more than most of those. There may be some that they don't know, but most of them will be that they have no symptoms, and therefore there is no onset. There's no date of onset of symptoms because there are no symptoms.
Right. Thanks.
In terms of case investigation and contact tracing, parish health departments have investigated all confirmed cases. We have traced over 3,600 named contacts of the confirmed cases at the 10th of May and have surveyed several communities. So these cases are really just a percentage of the number of persons that are interviewed, because we would have interviewed thousands of persons within communities, but then to identify contact, whether it is a close contact or a casual contact of the individual, we would have had 3,634 such contacts, and those would have been followed. The case investigation and contact tracing have yielded 412 cases so far, which is, of course, going to be our major pickup of new cases in these investigations. Communities surveyed: Bull Bay, Cornpeace, Hampstead, Somerstown, Breastwork, Springbank, Orange Bay, Enfield, Dover, and Nutter Bay. And well, now we have the St. Mary clusters that we are working on. But these would have been where we've had the larger clusters, and so we would have done extensive contact tracing and community surveillance, meaning fever and respiratory illness surveillance within these communities. In terms of the geographic spread of clusters, the same color is the same, is one cluster. So in the orange, which is the most noticeable, that would be the Alarica cluster. But you will see that the other clusters right across the island. So for example, and you can see from this the spread of the persons from the Alarica workplace cluster, because you will see the orange dots in other parishes. So these are where our major clusters are mapped, and
it looks pink on my screen.
Okay.
It's actually orange, remember.
Okay.
All right.
Go ahead.
Go ahead. Next slide. All right. So in terms of age distribution, I know that yesterday we were asked in the press conference about the children. We certainly know that at the start of this outbreak, both internationally and likewise here in Jamaica, we were seeing very small amount of involvement of our children. But as time has gone by, we have been picking up children who are affected. So you will notice in the 0 to 9 age group, we have 37 persons, and in the 10 to 19 age group, 60 persons. We categorize a child as up to 17 years, and up to that is actually about 57 persons who would be classified as children who would have been confirmed as positive. You will notice that the majority of these persons have really been confirmed through the case investigation with the workplace cluster.
Madam CMO, just a little clarification. Under Jamaican law, a child is someone who has not yet attained the age of 18 years old. All right, so there was a time when we had a category up to 17. That is no longer the case on our statute book. So, and we've been trying to make it consistent across all areas of government.
Okay.
Just a note going forward.
Childhood goes up to 17 then.
So we include 17.
Up to, no, it's just under 18, yes.
Under 18.
That's the same thing, my dear.
Up to 17 is not under 18,
I'm sorry.
Member Golding. No.
Let me rephrase that. Under 18.
That's not the same thing, respectfully.
Yes, I just want to clarify that it is in fact under 18, so it includes the 17-year-olds. So
That was how I understood it.
So before.
And you said there are 57 of those, CMO?
Pardon?
You said there are 57 of those?
57 of those.
So the other 40 are 19-year-olds.
97 minus 57. 97, 40,
Well,
yes.
Well, you can take it from the workplace for cluster. So somebody in the workplace cluster would be 18 to. Oh,
Well, we did have
Thank you.
one person, 17-year-old. Right. So pretty much this is what the age distribution looks like. You can. In terms of sex distribution, you can see that in terms of females and males, we have the females outnumbering the males at this point in time with 61%. Well, total confirmed 60% being female and 40% male. Go on. In terms of geographic distribution, we have already pointed that out in terms of St. Catherine, Kingston and St. Andrew, Clarendon and St. Mary being our areas right now that we're having the largest numbers of persons. Frequency of symptoms, cough, fever, headache. Those are, so we have widened our symptom list and are collecting information. And we also utilize this information in terms of when we are doing any kind of surveillance, not just to say that it's just respiratory and fever that we look for, but because of this expanding symptom list that we are seeing, we would have also expanded this in when we are doing our activities on the field. In terms of the combinations of the top 6 symptoms, you can see here again that cough and fever still remains at the top of the list. Comorbidities, we have diabetes, cardiovascular diseases, and including hypertension and asthma being the top comorbidities within our group, which is pretty much in keeping with what happens in our population. And then we have our cases with chronic kidney disease that we know that the outcomes, what the studies are showing is chronic kidney disease and chronic respiratory illnesses are where we're seeing the most severe illnesses. Now they've shifted from the diabetes and the hypertension towards a new set of diseases that are going to be causing the more serious illnesses. So it's important for us to keep a listing and a check on the comorbidities, and for these patients we monitor them more closely. So in terms of our surveillance of our respiratory infections, we have confirmed 37 cases through respiratory surveillance so far. And again, just a reminder to say that our respiratory surveillance across the island is coming from our 320 plus health centers and our 25 hospitals, where any cases that we have of severe acute respiratory illnesses, lower respiratory tract infections, or influenza-like illnesses, we are sampling those cases. And so far our pickup has been that we have had 37 cases through this investigation. And essentially, outside of the peak, you can see that there has been a general increase in the number of cases that we are picking up.
None from any private facilities, CMO, because we were told that private facilities, some were included in the SARI, the Sentinel site, sorry.
Yes, we do have the sampling coming from the private hospitals as well. In terms of the private practitioners, most remember that our severe acute respiratory illnesses are going to be coming into hospitals, and the lower respiratory tract infections, those will come into hospital. But in terms of our influenza-like illnesses, as we have said before, we are encouraging our general practitioners to report these cases. And then this is one of our main thrusts through the use of these apps to get persons who are at home with these respiratory illnesses to report. I'm not sure if we've had any positive cases.
I've had about 4 referrals to hospitals from INI.
From GP?
From GP.
Okay. So the PS is reminding me that we've had 4 of our cases that were referrals. Yes, I do recall, because remember the first case was a referral from a private hospital. And yes, subsequently we do have had the referrals from private doctors and the private hospitals for cases that have been confirmed. So this is where the respiratory infections that we picked up from this respiratory surveillance are coming from. And you notice that they're coming from right across the island. 3 parishes that we have not picked up any cases through respiratory surveillance so far, and that is St. Thomas, Westmoreland, and Hanover. So the number of our unrelated clusters, we do see that is increasing. And the COVID, again, all parishes except Hanover still we have identified cases. Number of cases identified through respiratory surveillance has shown a general increase. So with regards to community transmission, while it is that we still have not met the criteria, and the criteria that we had outlined some time ago in terms of the unrelated clusters and the numbers of cases coming out of the surveillance, and the numbers of local transmission cases. In our discussion with PAHO WHO, we are still classified as clusters of cases, because you can see that our large numbers of cases are really coming from these large clusters that we have. So the case investigation and contact tracing, while labor intensive, is essential in the Jamaican situation for the identification of cases. And you can see that that is where we do pick up much of our casing through the contact tracing and through our general surveillance measures. That's our report for today.
Demo, could you go back to slide 22 for me? Yes. Surveillance of respiratory infections. Just looking at this suggests, if you look at the areas in which we have had significant increases in the numbers, KSA, St. Catherine, Clarendon, St. Mary, and Portland, where we have had numbers. I think those are the 4 parishes that have the greatest numbers. Is it that we are seeing the manifestation of some amount of spread from these positives in those communities which are presenting at the hospitals with respiratory infections? Because if you look at just your chart here and look at another chart that indicated where the greater numbers are, from my recollection, the areas are KSA, St. Catherine, Clarendon, St. Mary,
Yeah.
and
Yes.
Portland.
Right. Certainly, where we're going to be seeing the cases of ILIs and SARIs that are coming up that we can have no link to an imported case is going to be the areas where it is that we would have imported cases, and where it is that you would have picked up the cases of local transmission that we could link.
Mm-hmm.
How many SARI samples have we had? So by week, I think 17 was the last one you had there on the slide.
So
That was 30 something, 28 or.
so in terms of the
I'm not talking positives, I'm talking the total numbers of samples, because in the last meeting we asked that and that question was not able to be answered. I'm hoping that this week with the new numbers that could be answered today.
okay, what I have actually is a bar chart, and what it is showing is that actually our numbers of SARI cases are in fact keeping in what we would expect at this time of the year in comparison to other years. While we would have seen a dip in the numbers of ILI cases because the ILIs are staying home, we don't expect to see the same with the SARI and the LRTIs because those cases are going to present to hospital. So what I'm seeing is that for Epi Week 18, we would have about 20 cases, and I'm really trying to look across to see the numbers on the bar chart, that it would equate to about 20 cases that we've had in Epi Week 18. And in Epi Week 17, it looks like maybe about 18 cases. In Epi Week 16, we had a peak where we actually had more cases than we saw last year, where we saw about 32 cases in Epi Week 16. So those are the numbers for the SARIs that we have been getting. Those are what the numbers are like.
All right. Semo, would you say that we are flattening the curve at this point?
I would say that it is clear that if we had not put in the measures that we've put in, our numbers would have gone up. Because if we really, what a normal curve would look like would have been an exponential rise that would be for every one person, you get 2.5 cases that are infected. So if that is the exponential rise that you expect to see, any coming down of that is going to be flattening of the curve, and it's going to be dependent on the measures that you put in place to contain. I think that essentially, though, what is important is that we have been able to flatten the curve below our capacity to respond. And
Is that premature to say, Pierre? CMO?
Is that what?
Premature to say.
Well, we can only speak about what is happening now. And certainly now the curve is flattened as to where we would expect it to be without any control measures. Now, certainly what can happen next week or the week after, there could be any kind of incident that could occur, especially now we are trying to return our residents back to country. We can get a sudden increase in the number of cases. So in terms of interpreting where we are in terms of the flattening of the curve, we can only speak about the present now.
And on that note, CMO, can you say how many samples have been taken in St. Mary so far in the 3 quarantine areas?
Okay. So so far we've taken about 100 samples.
And have we reported on any of those?
Yes.
I know we have reported on some of those.
Well, I only know of 2 that we have not reported on. In terms of the first investigation was done on last week Thursday when we went into Enfield, and we did community respiratory and fever surveillance and sampling of contacts. And for that, we sampled 37 persons. And of those, we had 2 additional positive cases. So we've gotten back all of those results. Our next sampling day would have been on Saturday when we went into Dover and Annotto Bay. And we also did community surveillance with respect to respiratory and fever surveillance and contacts. and we collected another 47 samples. Of those, we've gotten back the result for 45, and the 45 have been negative so far. So essentially, our next step, so initially when we do this kind of contacts, this kind of investigation, our first step would be to look at those kinds of surveillance, respiratory surveillance, fever surveillance, and contacts. Then now, once we've seen the yield from that, it would now say what next to do. So because we've gotten low yields, I mean, we've picked up 2 additional cases in Enfield that are directly related to the cluster that is already there. But our next step now would be to do random testing, to do every certain amount of households, to do testing from those households. So that is what we are doing now in terms of when we go back to the communities for 2 or 3 days. This week, we're going to go back for sampling. For this time now, we will bring the mobile unit to the areas and we will just get the sampling, random sampling from the households. So as I said, and you can probably recognize the importance of that in trying to get the respiratory and fever surveillance done first.
Yeah. No,
Right, and now we move on to another phase in the investigation.
Is that it, member, or you have an additional question?
I just this is another question, which probably CMO. Okay, so that is where we are now, and you alluded to the strategy next. What's the next strategy?
Well, this week we have identified.
Not necessarily for St. Mary, I mean the general.
Generally, in terms of surveillance. Okay, so we spoke about that last week, not a guy, in terms of what we are doing now outside of the general surveillance protocol is now to expand the protocol to try to see if there are any targeted groups that are going to be, that we're going to be getting positives from. So we had mentioned it at the beginning, that eventually we would start to do targeted testing.
Yes, I'm hearing. We're not hearing anything here now.
Seem to have lost them.
Yes. Bill again. Minister will need to use his phone as he did last week.
Checking what's happening. The audio seemed to have got lost.
You're back now.
Okay. Still not hearing anything.
CMO?
I don't think so. I'm not seeing them.
No, I think that we've lost them.
We have lost them, yes.
Also last week.
Mm-hmm.
12, 10:42.
I'm not hearing anything. I don't know if you guys are hearing.
No.
They are not on.
Okay.
You never put up a fight. Paradise Plum. And keep it locked to PBCJ. This is your girl, Naomi Cowan.
You'll always remember that day you became a parent. That day, you made yourself a promise to provide for them, to protect them, laugh with them, watch them learn, and let them grow. That day, you realized your biggest challenge lies in bringing them up in a world full of choices. That day, you knew they would grow up fast, and the innocence you cherish wouldn't last. That day, you made up your mind that no matter how things change, you would always take the time to give them parental guidance. That day is today.
Remember, parental controls are available for all devices. A reminder from the Broadcasting Commission.
I'm standing in the heart of Jamaica. Spanning from Wakefield Trelawney in the north, as far as Catadupa, St. James in the west, to the Appleton Valley in St. Elizabeth in the south, and stretching to Norwood St. Anne in the east. This is cockpit country. In 2017, the Jamaican government announced that over 74,000 hectares of cockpit country would be declared protected and closed to mining. They draw a line on a map where they want this cockpit country protected area to be. But before they can protect it under Jamaican law, they have to make sure of its exact boundary on the ground. This process is known as ground truthing. Ground truthing experts must walk along the boundary.
Dr. Guy, is that we, as you know, the country is looking at reopening and to slowly bring back things normal. As such, from the health sector, we have to now look at enhancing our capacity to respond. So there are various measures that we are looking at to ensure, because certainly we expect that if we start to do this, that we are going to get more cases that we're going to be picking up. And therefore, our ability to contain these cases, ability to pretty much, once there is any kind of outbreak, to very quickly be able to direct our resources into that area to be able to tamp down any kind of uprising there is what is important. And the measures that we need to do this lie within 8 different areas. And one of the biggest area that is of importance is really in terms of education, because it has to come from personal responsibility that persons have to employ in order to understand the risk to themselves, their immediate families, their community, and to the country as a whole. So health education is an area that we continue to focus on, but
Member Guy, the Prime Minister has appointed an economic task force, which has a number of subcommittees, one of which is the Resilient subcommittee, which I chair, and which has on it a number of players in the private sector and otherwise. So our job is to outline a plan that would allow us to respond to COVID over the next 12 months or so. So it's really about living with COVID as opposed to eliminating COVID, because we all know it's going to be here. That plan is now in train. I'm hoping in another few weeks to have a sort of framework for the plan, which would then feed into the overall task force. So it's a combination of new protocols, protocols around work, protocols around travel, protocols around congregating in social tourism industry, that sort of thing. You've heard us doing protocols for BPO. So it's about protocols, it's about testing and the approach to testing. And of course, it's about engaging additional capacity to go into communities, as we have discussed when we just started. So there is a plan that is now being fine-tuned or developed via that subcommittee, and it will be juxtaposed against a modeling of how we see the virus evolving over the next 12 months, which our epidemiologists and our team are putting together. So I'll be happy to share those information and specifics with the committee, just to reassure the committee members and Jamaica that that is something that is occupying our minds right now via the subcommittee on resilience as part of the overall economic recovery.
Just one little thing on this final before you go to the next member, Chairman. CMO, you mentioned targeted groups. Can you elaborate on that for me, outside of any what you may see, as you said, if testing reveals that
Targeted groups? What do you mean by? You mean vulnerable groups?
no, man, targeted groups in terms of the next phase. She mentioned targeted groups in the expanded protocols.
Oh, I see. I see.
Right. So you know that we already spoke about the hospitals in terms of testing and the healthcare workers. So we're also looking at the infirmaries, and somebody mentioned the expansion to include the other facilities for the aged. So that is another area that we've started to work on. We're also have been discussing sports sector as another area that we would like to do some targeted investigations in. So
what sector was that? You chipped out for a minute. What sector was that?
Transport.
Taxis and buses.
Taxis and buses.
Okay.
Right. So that is where we have started our discussion, Dr. Guy. As time goes by, you know, we would reevaluate, but that's what we are starting to work on now.
Can I get Member Holness now to just quickly ask her question? Member Holness?
Yes, just a quick question, CMO. As it relates to persons who had tested positive before and recovered, I noticed we are over 90 cases. And I saw internationally where there was some report of persons testing positive again. One, is that possible? And if so, would we be going through a round of testing persons who were previously positive and recovered? And number three, would they, if tested positive again, be persons who could possibly reinfect?
So some of those questions, I think the world is waiting on the answers based on, you know, the continued investigation of the disease. What I can say that from our perspective, we are being very rigorous in terms of our discharge testing. We are following the protocol to have 2 negative tests before persons are discharged. But we bear in mind that, you know, across the world, what we are seeing are very long times before persons become negative. So we're talking about 3 to 4 weeks. Now, what is not clear to the health community is whether or not persons are actually infective and are transmitting the disease during those latter stages of them being positive, because we have not been able to say yet whether or not you actually have virus that active virus that is present, or if it is just viral particles that are giving the positive tests. Because we know that even in certain samples that of other body fluids that we've had positive tests, not necessarily the virus that is actually present, but viral particles. And you know, in those instances, they would not be transmitting the disease. So
the science is evolving, and Therefore, we will still have to watch and see, member. I think that's what the CMO is saying. Sorry to put words in her mouth. Member Brown-Burke, you have a question?
Yeah, yes, I do. Minister, we keep talking about doing all that we can do, and I think the last press conference or the one before, I heard the Prime Minister say that the government is doing everything they can do, and it is now left in the community hands. So that if there is an outbreak, if there's a spike, then it's not the government's responsibility, it's those individuals who are not doing what they should be doing. So I wanted to just kind of look at some of the things that...
Are you sure that's what the Prime Minister said?
No, I'm telling you what I interpreted. He said, I told you what he said, which is that the government is doing all they can. It is now up to the community. That's what he said. And my interpretation is what I gave. And I can only be responsible for my interpretation, no one else is. But I wanted to go beyond that, because whenever we talk about personal responsibility and we talk about community action, I think it is always important for us to see those who may not be able to do what we expect of them and how we can help them do it. I believe that that's our responsibility. And that's where I'm coming from with what I'm asking. So I want to ask, how can we help in terms of the personal responsibility, community action that is expected? I hear about the public education, but I'm talking about those who cannot afford the masks, those who have underlying conditions, and who might need some help in terms of their their prescriptions, and just making sure that they maintain good health. I'm talking about what's happening in terms of water. So, I mean, what can we do? Are we monitoring those? Are we making sure that we are putting individuals in the best position to do their part?
If I may, part of the expanded army of public health and engagement that we will have will involve persons at the community level operating by the health centers, who will help to coordinate on the ground in the communities. Part of the one-to-one direct communication around COVID. What are persons expected to protect themselves, whether it's through brochures, personal interaction, but it's also part of the conduit, those individuals through the community-based groups, the SDC, the Citizens Association, the political electorate, the politicians, councillors, MPs, and so on, who themselves carry significant influence in those communities, who will therefore be given an opportunity through direct contact to satisfy themselves so that they can become transmitters of information and hopefully community action. Beyond that, as you know, the cabinet and the subcommittee, a subcommittee of cabinet which was set up weekly, discusses the deployment of resources in one way, shape, or form, including water and other scarce resources in some of these communities, so that we can enhance the mitigation measure to dealing with the issues. So I think there have been several ways to communicate. There's the overarching public education via main media. Mm-hmm. There is the underground communication via the community-based groups and the public health people in the community. And there's the coordination that is taking place at the level of policy to dealing with some of the specific initiatives that would enhance the capacity of those communities. If persons want information, they can call the number. We're promoting it, the 888 One Love number. And for now, that really is the sort of generalized approach. But there's going to be and has been targeted approach for places where the vulnerabilities are higher. So you mentioned the infirmaries and health centers and so on, where intervention is required. And we fully appreciate, member, you're correct, that we have and target those areas in particular. So that is kind of the generalized approach, with the specific initiatives can be outlined as required. Okay.
No,
Yes.
no, Chairman, just to make sure that you're clear on what I am saying. So I know we're doing something, for example, with food. We had Water Commission last week discussing water, so I know we're looking at that. I'm just saying, I think we need to just kind of monitor the water as we go forward. You know, I've also been talking about vulnerable groups in terms of those now who are at home and with comorbidities, as we like to call it. And I'm just talking because one is public education, but the other is it takes more than just public education to wear a mask. You know, if the last $200 I have really has to go buy a pound of rice and some mackerel, I'm not going to use that to buy the mask. So I'm asking us to just look at these additional things, like the mask, for example, like what's happening with prescriptions for individuals who have some of these underlying conditions. And I mean, that's all I'm asking.
Right. No, that's fine. It's a fair question. So as you know, we have done things like we spoke earlier about the outsourcing of certain conditions to try and ease some of the burden on the public system, which is ongoing. The NHF, for example, on medication is now doing home delivery. They have a new system that they are piloting. And in the communities that have been quarantined, they go into those communities and fill prescriptions and so on. So I agree with you that those are areas that need to be covered. And indeed, some of those areas are being covered. But we plan and we implement as we go along based on what the particular community needs. All right. Thank you very much, member, for that. Lynn, your hand was next in line.
Thank you. Chairman, I have two questions. The first relates to the somewhat alarming scenes that were in videos and so on over the last few days arising from the payments via the remittance services, for example, and the crowds that have been congregating outside of various remittance outlets as a result of the way in which that is being managed. And I'm wondering from a public health perspective, what is going to happen to eliminate that kind of large congregating of persons, which we know is potentially dangerous for the spread of the virus? That's my first question.
Okay. Concern, and it's a matter that has been discussed at the highest level, at the cabinet level. There have been some adjustments made, recommended, and some made. For example, today, for the KSA area, the Western Union organization has been relocated to the national stadium using a series of windows. Persons have been referred, or the excess capacity have been referred there. I think that is going on as we speak. With health has been present. I've dispatched a team there to work with them to help them manage the social distancing issues and minimize or mitigate against the potential risk. Elsewhere in the country, the health authorities have been asked to communicate with the particular private sector entity to coordinate and to assist with some of that, crowd management, if you will. So the answer to your question, that is yes, it is an issue. It is a concern, and hence the interventions that have been made, including today, where we have relocated some of the activities to a bigger space where we can have the crowd control under better management. Of course, you appreciate the value of the exercise. I mean, it is helping persons who are unemployed or being challenged at this time. And so we fully understand the anxieties in collection to satisfy their particular needs. But the public health issue also is very important, since this is the whole cause of everything. Next, you have another question, member?
Yes, I had one other question, but just to say, yes, I mean, the whole question of the efficacy and the breadth and the gaps in the care program is probably beyond the purview of this committee. But the other question I have relates to an issue I've raised before, which is vulnerable groups, and in particular elderly, but also persons with comorbidities who are in densely populated communities. And you had told me that you have a strategy that is being developed for mitigating the risks that those people face if community spread reaches those very densely populated areas, where you have yards with multiple dwellings, multiple persons living in single rooms, etc. Elderly people, persons with comorbidities being particularly exposed, and social distancing being virtually impossible. Where are we with that strategy?
Okay, so that strategy is well advanced in that you would have seen, I believe, in the public space, not at this committee, the Paris Hawaii presentation around mapping vulnerable communities, which involved the identification of a number of communities based on some variables, including comorbidity issues, the hypertensive, diabetic patients, densely populated areas with some amenity, lack of amenities and so on. That document was completed, which identified a number of communities. I believe it was 20 in the first instance. And the PSOJ and ourselves have had discussions along with other agencies, Ministry of Labor and so on. And they have actually commenced providing some support on their initiative in those communities. Our plan for a more sustainable, longer-term approach is captured in the the committee that I mentioned earlier, which is the Resilient Subcommittee, where the intention is to develop the capacity through the additional personnel who will be placed in those communities to develop the protocols around how life as we know it would need to be adjusted to dealing with those, and to assess and develop the additional infrastructure that would be required should there need to be relocations because of the risk of the virus touching down in any of these areas. So in a sense, the plan is evolving, starting with the Paris Hawaii document, evolving into the Resilient document for a more broad-based national approach, because in fairness, that document is limited to 20 communities. And as you know, there are far more than 20 communities that offer those levels of vulnerabilities across the country. So I'm hoping that we will have a better handle once we work out those protocols and extend the capacity by the end of this month to be in a better position to at least track, inform, educate, and influence some of those communities and to respond where the response is required.
Will that document be made public, or will we see it? I mean, whatever that output is of that resilience committee, taking into account Paris Hawaii's analysis of the communities and so on, and then actually with what would be the tactics or strategies for addressing these concerns. Is that going to be in a position paper? How would we be able to see what is actually
the subcommittee is going to transload the position into the wider Economic Recovery Committee document and provide the public health guidance to the overarching holistic document. So that's the intention. I assume it will be a very public document in Parliament.
So there's no intention to have this committee consider it and comment on it? The public health aspects of it. I mean,
we'll certainly take the document from the Resilient Committee to this body for a discussion around it. I have no problems with that at all.
Thank you.
Thank you. Member Holness, you have your hand up. Another question? Member Holness? No? All right. Anybody else? I want to go into any other business.
Yes, Chairman.
Hello, Minister.
Yes, Member Holness.
Just a quick question. As it relates to one vulnerable group that we have sort of forgotten as we have progressed, the prison. I know that they have been under lockdown for some time. I'm not sure if you'd be able to report what would be the continued approach in terms of our prisons and whether or not we would be moving in opening up to open up that particular vulnerable group who would be in a sort of overcrowded situation.
Well, the minister with responsibility for prisons in the Ministry of National Security is Minister Matthew Samuda. He has been coordinating with health the approach to the prisons as part of our efforts to mitigate against an outbreak of COVID in that facility. There has been some standard operating procedures that have been implemented. I don't know that that is going to change right now because the concerns clearly would be the risks associated with changes. So the issues of visitation and things like that are restricted. I think for the time being, we'll have to continue on that trajectory until we are better able to manage the situation. So I really can't comment beyond that. I could try to get a brief from security, based on the discussions they have been having with health. But as I said, I know they're in touch and I know they've been following certain procedures. Okay. All right, Member Brown-Burke, your hand is up.
Sure, thank you, Chairman. Chairman, just simply the care grants. I believe that we need to have a process of appeals. So people who are having issues, and some of it is not even appeals, it's appeals and just queries. There are a lot of little issues that persons are having. And it has been very difficult for many of them to get responses. So if I sent in my bank account, but I haven't used the bank account for 5 years, it's now, I'm being told that it is closed. What do I do? It's very, very difficult. And I'm just thinking that we need to have a window, a number where persons can actually discuss the issues that they're having with a view to seeing how they can be resolved.
I believe that the website does allow for that, to be honest with you.
It isn't flexible enough, Minister.
Okay, I'll check with the minister. You and I and him sit in a similar place this afternoon. Maybe we should raise that with him and
No
get
problem.
feedback on him. All right, thanks a lot.
ID issues as well, Chairman. Persons who don't have their voter's ID for whatever reason, yet it hasn't been issued or whatever, or they may have lost it. Is there any alternative way that they could be identified for the purpose of collecting their grant? Can a letter from a JP suffice, or from their MP or councillor? Some flexibility around these issues. These are real problems on the ground.
I'm going to ask that we raise that with the minister with direct responsibility later on. Any other business?
Chairman.
Yes, member.
I've been asked to ask this question. There is supposed to be a ship due in on Wednesday in Falmouth. I think it's Adventures of the Sea. And I suspect some Jamaicans will be repatriated. The ship will be in dock for about 5 or 6 days. Is it expected that the Jamaicans who will be landed will go into a government quarantine facility and would also be the subject of the same processes that exist for those who return by airline?
Well, let me just articulate the principle and then address the specifics. The principle is that anyone coming into the country as of now is required to be quarantined for the stipulated 14-day period under supervision of the health authorities with certain requirements of, and the testing and so on. And the general rule is for state quarantine with some exceptions if necessary, illness, whatever, for home quarantine. As it relates, that would apply whether you're coming on a plane or on a ship. So to the extent that any ship is coming in, that procedure, standard procedure would apply. Nobody would come off and just be allowed to go. For now anyway, until the rule changes. And I'm sure the country appreciates why this is the case. As it relates to the specifics of a ship coming in next Wednesday, remember you seem to have more information than I. I will do some checks on that, but I'm just checking my CMO here and she's not aware of those details. I know there are discussions taking place around the possibility of seamen, meaning Jamaican workers on ships, being repatriated. Are in the process of trying to work out logistics around these arrangements, but I can't say that I have been given any specific date. And so your level of detail makes you a lot more aware on the specifics of that particular approach. But the general approach,
Minister, no. The question I asked, is it's supposed to, I'm told it's supposed to arrive on the 15th and will depart on the 23rd. The question that arose that allows me to ask you that was whether they would be quarantined on the ship as part of the thing. And I understand the protocol that you're saying and I respect it. And that's the one that I told them as well. But the fact that the question was asked, I felt duty bound to ask you.
No, that's fine. We appreciate your questions. No, the protocol would have to apply. And in this instance, I'm aware of those specifics of a particular ship coming in next week. Any other matter arising?
Minister, just one question. From your perspective, we are now in mid-May, and we have been told that the tourism sector is hoping to reopen in June. How will that work from the point of view of ensuring appropriate protocols for persons coming into Jamaica if we open our borders to tourists? And the whole need to quarantine and test and all the rest of it. Is that, from your perspective, how do you see that working?
I would prefer not to offer a personal perspective at this time. There is a committee member that, as I said earlier, a resilient committee with a cross-section of persons supported by public health who are now working out protocols around a range of areas, including tourism. And I really would prefer those protocols to be signed off on before we get into the speculation, because of course that could lead to all sorts of issues. I know there has been some dates that are advanced, not all of it based on guidelines from public health. I mean, I hear the cruise ships have indicated dates that they will sail. Particular organizations have done the same. Public health clearly is providing the guidance to cabinet for the decisions. I have to rest with the decisions that cabinet makes based on the conversations with public health and others. And as of now, no set date has been arrived at, even though there are views around when we probably should be looking based on what's happening on the ground. So it will be guided, but those protocols are a work in progress as we speak. Thank you very much.
Understood.
Any other question under any other business? No? All right, so members, I want to thank you very much. Again, apologize for the late start. I'll try to make it up in meetings to come. Next meeting, I'm going to work on the on getting the nursing homes or the regular nursing homes to, based on member Angela Brownberg's request, and so that we can have a conversation as it relates to that vulnerable community. And then if there is another, I may invite our epidemiologists to look at the modeling for the next 12 months based on what is being worked on. So it gives us an idea, and we could juxtapose the plans against that, which includes opening up some of these industries that member.
Chairman?
Yes, sir.
Just one, in terms of the field hospital at the arena, is that still being pursued?
As far as I know, yes. That was asked in the press brief yesterday, and I was told that a contract was negotiated and it will be under the supervision of the JDF, and that they are proceeding. I haven't heard anything subsequent to that. So
Who is
yes.
the contractor, Chairman?
Who is it?
Contractor.
I was told yesterday that the contractor was Rogers Construction, right? Rogers Construction.
Okay.
Okay. All right. So thank you very much. I will see most of you, if not all, in a short while. And all the best to you. And thanks again for your contribution. Thank you. Meeting adjourned. So moved by Member Guy, seconded by Member Brownberg. Okay, great. Thank you very much.
She want a lover, man. She want a lover, man.
Woman want good love. Now sympathize. Woman want good love every night. Right now. Love a girl. I mean, step up.
She want a lover, man.
Action. That's a bag of mouth. So we. Don't be with the girl them broke out. Action. That's a bag of mouth. So we.
And I don't got me never in love. And I don't got me never in love. Come me a winner in love. Me no spinner in love. And I don't got me never in love. And I don't got me never give me heart. Still look, I ain't gonna see me bar. Come me a winner in love. Me no spinner in love. And I don't got me never in love. Hey, this is Nadine Sutherland. You're watching PBCJ, the People's Station. Keep it locked, you know. Keep it locked.
She want a lover, man.
The good news is you can protect yourself and your family against the coronavirus called COVID-19. When you come in from outside, before you eat, and after using the bathroom, wash your hands properly. Protect yourself and your parents from the coronavirus or COVID-19.
Imagine a better life for children.
Imagine better food and water for children.
Imagine more freedom of expression for children.
Imagine there's no children with HIV.
Imagine no more child labor.
Imagine better health care for children.
Imagine there's no heaven. It's easy if you try.
No hell below us. Above us only sky.
Imagine all the people living for today.
Imagine better sanitary conveniences for children.
Imagine better maternal care for children.
Imagine more leisure for children.
Imagine a world with better sports for children.
Imagine there's no countries. It isn't hard to do.
Nothing to kill or die for. And no religion too. Imagine all the people living life in peace. Woo-hoo.
You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us. And the world will live as one.
Imagine better parenting for children.
Imagine better education for children.
Imagine more inclusion for children with disabilities.
Imagine no child being abused in any way.
Imagine no possessions. I wonder if you can. No need for greed or hunger. A brotherhood of man.
Imagine all the people sharing all the world. You may say I'm a dreamer, but I'm not the only one.
I hope someday we'll join up, and the world will live as one.
Reimagine a better future for children.
You told me that I can be who I want to be. You say that I'm the future,